Welcome to the Department of Cardiology, PGI Chandigarh. Let me introduce my team. I do have Dr. Basan, Associate Professor, Department of Cardiology. Along with him, I do have the team of Dr. Vikram. He is the post-DM resident of mine, and Dr. Parminder is again the senior resident. So we do have this interesting case with us. Can you show us the PowerPoint slide, please? And Dr. Basant, can you narrate what the case is about?
Thank you, sir. We do have a very interesting case today, the multivessel precision PCI. So this 50-year-old gentleman presented with us the class 2 angina since last 2 months. He's a hypertensive, non-diabetic, and the clinical examination was unremarkable. The BMI was 24.6 kg per meter square. His renal function was okay. eGFR is 90 ml per minute per meter square. The lipid profile is okay. His LDL cholesterol is 57 and total cholesterol is 130. LDL, HDL is 35 and triglyceride was also 192 milligram percent. And he was atorvastatin 20 milligram daily. The past history is also significant. He underwent the PCI of proximal LAD in 2003, to almost 20 years back, and the PCI to OM in 2017, almost 7 years back. The PCI to late ISR LAD 2021, almost 3 years back. Yeah, this is the ECG just showing. ECG is unremarkable, and echo is also showing no LV, RWMA, and EF is well preserved. So here we have an angiogram in 2017 when he presented with unstable angina. The RCA was normal, the LAD stent was patent, and there was significant OM disease for which the ostial LCX 3 into 5 into 28, 3.5 28 Xience stent was implanted and having good result. So 2021, and again he presented with chronic stable angina class 3 of 3-month durations, where you can see the patent stent in the LCX, but the proximal LAD had a late ISR of Taxus stent 3 into 60 mm stent of almost it was implanted 18 years back. So this is the OCT of LAD, which is showing the heterogeneous fibrofatty focal ISR, and for which we implanted proximal LAD 3.5 into 20 mm synergy stent. Next. And this is the post PCI FFR of distal LAD and D2, which was 0.82 and 0.83 in LAD and D2.
At this point of time, we had an angiography done, which shows the patent L6 stent, patent LAD stent. Next view, please. And this is the diagonal D2, which is disease. Last time we had FFR done across it in 2021 when it was 0.83 and the LAD was 0.82. Here both the vessel LAD and also the D1 is having the significant stenosis. Distal LAD is cut off. Next view, please. Next view. And this is the RCA. The RCA was normal throughout the course, and at this moment of time, when he again present with the angina, had a PLV, which is significantly diseased, and then proximal to mid RCA is also having some insignificant disease. Next view, please. So we have taken the JAR guide to cross the lesion with the BMW wire, dilated with 2.5 15 millimeter balloons, a 2.5 23 millimeter Xience stent been deployed in the PLV. Next, we did the OCT after implanting the stent across the PLV branch, which showed. Can you run the OCT image, please? So this is distal end of the stent, which is good with no dissection. We have a well opposed stent across the PLV branch. Proximally, we have fine. There is no dissection as such. And here the Nikhil, what's the size of the PLV? Can you comment about? So it's a 3.1 millimeter. That's the importance of the imaging. Here the PLV size, which seems to be say 2.5 on angiography. We did go ahead with a 2.5 millimeter stent, but then our imaging did show us that the size is of course the 3 millimeter, and therefore can you show this? And meanwhile we also had now OCT run on the proximal RCA, which angiographically doesn't seems to be so significant. And can you show the run of the proximal RCA? Here is the proximal RCA, which at the particular point, the tightest point, do show the minimal luminal area of 2.26 millimeter square, which is quite significant. Can you show this angiogram? And what about the characteristic of the plaque over here? Nikhil, can you comment about what's no, there is no calcium as such, but then there's a lipid rich and the fibrosis which is there over here. And can you demonstrate some ulcerated plaque, also sorry, thin cap fibroathyroma? So here is at say 1 o'clock. There is a thin cap fibroathyroma, and there is some thrombus as well, or ulcerated plaque. I think it's ulcerated plaque over here in the proximal RCA, with the area which turned out to be say 2.26. We dilated the PLV stent with a 3 millimeter balloon, 3 millimeter NC balloon. Next view, please. And this is what the final result across the PLV, good flow across. And meanwhile you can very well see angiographically there is some disease in the proximal part, for which we have done the OCT. And let's have a look on the FFR as well, how much the FFR value is going to be there across the proximal RCA, and then decide about the study of revascularization. So what we do have across this proximal segment, PD by PA of 0.97, and what's RFR? Okay, 0.95. So 0.95 is RFR across the RCA. And let's have a look on post adenosine FFR value. So kindly give the adenosine. It's fine, and some bradycardia, but it's fine. And we do have an FFR of say 0.84. So now we are really concerned about with the FFR value, which turned out to be the 0.84, and then the area is 2.26, which is really a concern. But if you see this particular angiogram, there is some ulcerated plaque at this point. Angiographically, there is some dye staining at that particular point. And then OCT has also shown then thin cap fibroathyroma with some ulceration over there, and therefore this is the case. We are the part of combined intervention trial, where the criteria to go ahead for the revascularization in those with the gray zone FFR is in case it turn out to be MLA of less than 2.5 millimeter square, and then thin cap fibroathyroma and ulcerated plaque. So Nikhil, can you comment about what the size of RCA distally? What's the reference diameter? 3.75. So let's go ahead for the 3.5. And how much is the length? 33. So let's go ahead for 3.5, 38. Uh, Giants expedition. Proximal part of the RCA is 3.9. So here we are across the proximal RCA, and I think we are okay to go ahead for. Can you give the 4 millimeter NC balloon?
Yes.
Yes, we are within the stand. Go ahead, inflate. 2,
2,
4,
4,
6,
6,
8,
8,
10,
10,
12,
12,
15,
15.
negative. So it's a 4 millimeter NC balloon, which we have inflated at 12 atmosphere. And go ahead.
6,
8,
8,
10,
10,
12,
12,
15,
15.
negative. So this is what we have achieved. Good flow across the right coronary artery, distally as well as the proximal stented segment. And let's assess the proximal segment of the RCA with the OCT. What the result is. We are across the stented proximal RCA, and let's have a look on in the OCT whether the result is optimal or not. So this is the area non-stented segment, and the stent there is no edge dissection distally. We do have good opposition across the distal part, and let's see the proximally as well. This is what we have achieved across the right coronary artery. We have taken the EBU guide via the right transradial access, though patient was having some pain, but we could go ahead given some analgesic for the pain relief, and let us go ahead for the FFR across the diagonal and also the LAD. It's the EBU guide to cannulate the left horn system. We could pass here the wire across the LAD. We do have now baseline PD by PA of 0.84. RFR is 0.76. So RFR is otherwise significant across the diagonal, but let's go ahead and give the intracoronary adenosine to look for this. So we are given 200 microgram adenosine across the left system, and the FFR turned out to be how much? 0.77? 0.76. So this diagonal is significant. Let me have a look on the LAD as well. LAD distal is cut off, and then let's see how important it is without having any distal flow. Is it really significant functionally or not? There are good amount of septal which is arising from the distal LAD, and how much myocardium is under the jeopardy, that has to be looked into. And then here, so for the LAD we do have now PD by PA, resting PD by PA of 0.88, and RFR of how much? 0.82. 0.82. So which is significant, and let's give the intracoronary adenosine for the LAD as well, and then decide about how much it turned out to be. So the FFR across the LAD is how much? It's a 0.79. So there is a significant supply of the LAD territory as well. So both the vessels are significantly diseased and needs the revascularization. So now it's a 2.5 millimeter balloon across the diagonal. Let me dilate it. Go ahead. So it's a 2.5, 8, 10,
8, 10,
12.
12.
It's a 2.5, 18 Xience across the diagonal. The focal lesion, which has been dilated with a 2.5, followed by the 2.5, 18 is stent. So this is what the result is across the diagonal. Let me have a look in the OCT whether the result is okay or not. So just show the standard segment, though the quality is not so good. But let's see, what's the size of the vessel over here? 2.4. So we have already put a 2.5. Uh, mm. So the size of the stent proximally is around 2.75 plus. So let me dilate it with a 2.75 NC balloon across the stented segment, and then proceed for the LAD. So now we are there with the 2.75 NC inflict.
10,
12,
12,
15,
15.
negative. So this is what we have achieved across the diagonal, a good flow across it, and let's go ahead for the LAD. Negative.
Ah,
Inflate.
6, 8, 10, 12.
Negative. So it's after 2.5 millimeter balloon dilatation. We have this result across, um, and the diagonal otherwise is fine. Let me have a look on the OCT what the size is. Can you run it and see the distal reference? Though it's a diffuse disease. Let's have a look. What's the size over here? 2.5. So basically it's a 2.5 millimeter vessel which has been dilated with a 2.5 balloon. How much is the size across the bifurcation? This is the point of bifurcation. What's the size just proximal to it? It's a 3. So distally we do a reference of 2.5 proximally at the level of bifurcation, and proximal to it turn out to be 3 millimeter vessel. So now we are here across the distal LAD with the 2.538. We have nicely covered the lesion, and the proximal end of the stent is at the bifurcation. Negative. Inflate.
4,
6,
6,
8,
8,
10.
10.
Negative. So it's a 2.538 been deployed at the distal LAD involving the bifurcation as well. Inflate. So this is 2.75, 15 NC
See,
balloon, 12,
12,
15,
15,
negative, 12,
12, sir.
15,
15,
negative, 12,
12,
15,
15,
18,
18.
negative. We have used the stent boost to look for whether we have covered the whole segment prior to bifurcation, and here you can very well appreciate we have deployed this distal LED stent with the opposition of the already deployed proximal to mid LED stent. So let's inflate with a 3 millimeter NC balloon over here at the bifurcation point.
12.
Here we are done, and negative. We have the ACT which is around 300. Um, which is okay for this PCI procedure. We have some angiographic narrowing across the diagonal. Otherwise, the result is fine. Let me have a look on the diagonal with the FFR. In case it turn out to be significant, we can very well have a balloon dilatation over there. So give me FFR wire for the diagonal. So here is the FFR wire across the diagonal, and let me remove the another BMW wire across the diagonal to look for how much is the FFR value. PD by PA is 0.93. How much is the RFR? 0.88. And let me give some adenosine to look for the diagonal significance. So it's a 0.86, 0.87. So this is very much suggestive that there is no need to have any further intervention at the ostium of the diagonal. Let me have the final angiogram across both the vessels. So this is the final result. Good flow across the diagonal and also the LAD. So this is the case about late ISR of Taxus is stent across the LAD, and then LCX, which is a new disease in 2017. Later on, 2021, the late ISR of the LAD, which was treated, and then again he had a problem in the right PLV, proximal RCA, distal LAD, and also the diagonal, which has been treated with the help of functional assessment and also intravascular imaging with the satisfactory result across all the treated segment. Thanks for being with us.